masterclass for the first 5 weeks in infection prevention control with the third wave of COVID. And really, this is a great opportunity for me to learn as much as it is for anyone else, really, to listen to the contributions that the panel are going to make, and to answer lots of questions, hopefully, that we will get from you. So I'll move around the screen. I'll go to David first.
Thanks, Amanda. Hi, everyone. I'm David Crampsey. I'm the Executive Medical Director, and I'm also the Chair of the Clinical Reference Group, which we'll refer to later, which has been part, again, of our approach to PPE and IPC in the organisation.
Lovely. Alison?
Morning, I'm Alison Charlesworth, Matron for Infection Prevention.
David Moss?
Good morning, everyone. I'm David Moss. I'm the Managing Director for AGH Solutions.
Alex?
Good morning, I'm Alex Doneski. I'm an ED consultant, and I've been doing a sort of COVID leadership role throughout the pandemic for the Emergency Department and Urgent Care, and I've been responsible for implementing a lot of the IPC guidance in clinical areas.
Trudy?
Morning, everybody. I'm Trudy Balderson, Head of Community Services for Airedale.
She?
Morning, everyone. I'm Machine, Senior Contracts Manager from Procurement.
Lovely, thanks. And I know joining us is some of the infection prevention control team as well. So just to acknowledge that they're here and in David's office. Marco?
Hi, good morning all. I'm Marco Lee, a consultant microbiologist and infection control doctor at Airedale.
Lovely, thank you. So we have got an agenda. We are going to start with David around the role of CRG, and then each of the team are going to contribute a section on sort of all themes related to IPC. So we hope you enjoy it. We hope it generates some good questions as well. And there are no daft questions, so please be confident to ask any question you like. With that, I'm just going to just do a little introduction. So we started off in January in the Trust, heading into a third wave, a significant third wave, which was different to the previous two, and we saw significant numbers. And with the new variants, we also saw a significant number of outbreaks in the Trust. We went up to, I think at its peak, we were at 7 wards, Alison, weren't we, in terms of trying to manage that. The Trust managed those phenomenally well. It was a real response, a positive response from everybody involved in those. And it did put significant pressure on the organisation in terms of how we cared and managed for our patients across the hospital. But it was really just to acknowledge that and how that was managed in terms of making sure that we were cleaning right, that we weren't moving patients inappropriately, that we were adhering to PPE. And what you'll hear through the webinar, hopefully, and Alison will touch on this, is some of the new things we've brought in during this last few weeks that hopefully have contributed to managing some of our infection prevention control challenges that COVID has brought to us. But I'm going to hand over to David next to talk about the clinical reference group. David?
Thanks, Amanda. So I'm pleased that I'm actually joined by some clinical reference group members today. So Alex and Marco are regular attenders. Trudy and Trudy's team also have been there. Nikki, Alison and many others have come to what was a meeting that was set up really right at the start of the pandemic. And actually, as we prepared for today, I was reflecting on what the real driver was for having a clinical reference group. It was actually in relation to PPE and IPC considerations at the very outset. So what we had was a situation where COVID obviously came to the UK in a way that we did anticipate because it had been in other parts of the world, but obviously it impacted quickly and at a scale such that some of the guidance at the very outset was either completely absent or had the potential to be conflicting. And what Brendan did as Chief Executive was he asked us to set up a clinical reference group which could help advise Gold's Command as part of our command and control structures in terms of the decisions that the Trust would make. So we deliberately set it up as a multi-professional clinical group. So broad representation from the nursing profession, AHPs, medical colleagues, healthcare scientists. And it's remained really a key part of the decision making for the Trust throughout the pandemic. So what I described at the start was the absence of guidance. quickly we started to encounter a very different problem, which was an absolute deluge of guidance, often coming in from various specialty organisations, from national bodies. And when we last did a count a few weeks ago, Clinical Reference Group had received over 1,000 documents, which we had either had to consider in detail or agree didn't need detailed consideration and could then let some of our other teams get on with what they needed to be doing. So that was really the basis in which we set it up. And I know, and Brendan's just given this commitment again this morning in another meeting, Clinical Reference Group is here to stay, to sit as a clinical advisory group to the organisation for all of its decision making, whether that's COVID related or not. But at the moment we remain focused on COVID related issues, and we meet twice a week, Tuesdays and Thursdays, and we've still got active information that we need to consider. I would also signal that we tested out some quite contentious areas. So one of the early tensions that we had was in relation to a difference between Public Health England guidance and Resus Council UK guidance in relation to resuscitation algorithms. And again, these differences of opinion were based on emerging science, emerging opinion, but we actually took a view that if we were to do something different in the organisation that meant that we would not adhere to Resus Council algorithms, that could have an immediate and quite practical impact on the way that we handled resuscitation situations for patients. So we made a recommendation to Gold Command that the Trust would consider to follow Resus Council UK algorithms. And indeed, we revisited that again recently. I think what I'd also say is it was another good example of where these weren't just decisions that we're making in relation to how our hospital teams carried out their practice. Trudy and colleagues had also made representations in that forum about the fact that these considerations equally needed to apply to our community teams, who might unfortunately also be involved in resuscitation situations out of the organisation. Indeed, often as a lone practitioner, Trudy, we might have colleagues who are involved in that situation. So again, using CRG's advisory function, we were able to essentially give colleagues some clarity and some cover from a clinical perspective when the organisation was making those decisions. Another example I'd reflected on was some guidance that came out from the Royal College of Surgeons several months back about how we should have theatre ventilation settings working. And actually, that guidance had to be retracted by the college very quickly afterwards because it had an error in it. And again, using the Clinical Reference Group as that multi-professional team who could check in and challenge guidance was a really effective way of making sure that we didn't get bounced into making unhelpful decisions, albeit for the right reasons. So I think again that just embedded why CRG has been a useful forum. The last thing I wanted to touch on was in relation to eye protection. So eye protection again is something that changed during the pandemic. So initially there wasn't a recommendation that everyone in clinical areas was wearing eye protection, but there started to emerge evidence that actually an ocular route was a potential significant route for transmission within hospital, both to patients and to staff members. So what we did is we encouraged that our staff working in clinical areas would be wearing eye protection at all times. And through CRG, we heard some concerns that some of the eye protection was actually just quite difficult to use. It didn't seem to fit very well, it wasn't comfortable. And using that intelligence through CRG, David and Nosheen's team in AJH Solutions were very quickly able to procure us some different eye protection, which has met with the satisfaction of our clinical teams and allowed them actually to wear their PPE in a much more consistent way. So I guess 3 examples of where we hope CRG has added value, and then ask again if there are issues, particularly from a clinical perspective, that you do think need to be considered. It remains a forum where we can hear those messages. I just want to pick up on 2 final things just as I close off this section. So the first is a frustration I know for many of our colleagues, which is that vaccination currently makes no difference to our practice. So it's really pleasing that so many of us have had our first vaccine, and indeed some people, based on their risk profile, have actually had their second vaccine as well. Regardless of that, you still need to wear recommended PPE in your areas. You're still operating in an environment where COVID is in that environment. Obviously, a hospital concentrates the number of sick people by de facto, we are an organisation that brings sick people together to care for them. So please do continue to wear PPE. There is emerging evidence that the vaccine hopefully not only is protecting individuals against the risk of severe COVID, but may also help reduce transmissibility. Do we hope that at some point in the future, things like vaccination and the lower prevalence of COVID might mean that we can do something different about PPE? Absolutely, but at the moment, please do not change your practice based on your vaccination status. So the last thing I wanted to touch on, and the reason I want to discuss this, is that colleagues will be aware of it from some national conversation, but also I know that Trudy's team had flagged this as well as a question that some of them have got, and it's as to whether we should be doing anything different at this stage in relation to the type of mask that people are wearing, and specifically our fluid-resistant surgical masks, such as the ones that Marco and I are wearing just now. Are those suitable for the areas in which we recommend that those are used, as distinct from FFP3 masks, which are very different looking masks, which are used in other parts of the organisation based on specific risk that sits in those areas. So currently, what we are doing is we are absolutely adhering to the Public Health England guidance, which would absolutely describe a situation where Marco and I wearing these masks, sitting sufficiently distanced, are a level of protection that is what is required. We know, however, that there's a bit of discussion in the media and in some professional bodies about whether the government should be doing what's called a precautionary approach and suggesting that people would wear a higher level of PPE than what is clinically required. I think what I also wanted to play in is to balance out that conversation. We've also got a number of colleagues who described to us just how challenging it can be wearing higher level PPE for a course of the day. So any people who have just been wearing a fluid resistant surgical mask who are asking whether they should be wearing a higher level mask, actually it's a significant additional burden. So unless there's a really good scientific reason for it, we'd be saying actually, it's not something that we would be recommending from that comfort perspective either. So we thought it was important just to touch on that point at this stage. Should the guidance change, should the evidence change, again, we would respond to that as a trust, and we would also consider it through CRG just in terms of approach. But we thought it was really important just to touch on that element today because we know that it's been a live topic for discussion. Are there areas of contentious national debate in other aspects of COVID management at the moment? Yes, so you'll be aware that initially the government's decision to split the COVID vaccination timings was something that was hugely criticised by a number of professionals, including some of my profession, including some of the nursing profession. But what we're hopefully beginning to see is that that strategy, which was a different strategy, has potentially been borne out. So it is fine to have these national debates, it's fine to have these conversations, and we're really glad that people are continuing to ask the questions, but we thought we'd just give that absolute clarity on the position at this stage. So that's all from me at that point, Amanda. I hope that's helpful for colleagues.
Thanks, David. That's great. We're going to move on, and Alison's going to come in because we felt there were many teams in the eye of this pandemic and impacted. Everybody's been impacted. But one of the teams that had to respond to this was the infection prevention control team. And we thought it'd be just good to hear from Alison and the team about how that's felt and the learning over the last 12 months. Alison?
Thanks, Amanda, David. I'd just like to take us back to some key dates in January 2020, when Wuhan was all over the news and my IPC antennae were twitching, and I was reflecting back on our Ebola experience and difficulties with sourcing PPE, difficulty with having guidance to follow. And I contacted Carol Woolgar, our emergency planner, and I just flagged it up and said, look, we need to get the ball rolling early. We need to get people in the room, and we need to get plans in place, and we need to get our foot in the door with the PPE requirements, because I know what happened previously. So I think I'd already learned from the Ebola experience to how it was going to feel if we had a situation. Obviously, we didn't have an Ebola situation, but we've certainly had a COVID-19 situation. And I've reflected back on some of the notes, and one of the comments in the first meeting, and I assume it was from another forum, emergency planning, was that it was not likely to spread in the UK like it had done in China. And that quite struck me reading that this morning, that we were in that place, and it was like, oh, you know, there were plenty of people in the room. Everybody had a different opinion of how this would play out. and we're here now, nearly a year down the line, and that's quite impactful, I think. And I don't think we've quite, in the infection prevention team, got to that point where you can fully debrief, and I assume other teams will feel the same. So at that point in time in January, we had a very small infection prevention team. In regards now, we probably still have quite a small infection prevention team compared to other trusts. I wasn't working full-time in infection prevention at that point. I was moved to infection prevention full-time in March. So at the point where the pandemic hit, we had 2 band 6s and a very new part-time band 6 who literally started with us, I think, in the February and had no IPC experience. So that was kind of like hitting the floor running. Starting your first IPC job in the midst of a pandemic was probably quite scary for Emily. So on the 18th of March, we had our first case in AGH, and I remember coming down to the exec team to report that case and feeling all sorts of emotions, really. It was kind of like, oh my God, we've got our first case, you know, and from then it just progressed, and within weeks the hospital was full of patients with COVID. It was a new virus, so staff, colleagues were looking to us to support them with that. There was an enormous amount of anxiety, and we became everybody's new best friend, or worst enemy in some cases. Because obviously we've just discussed the issue with PPE, and it's not very nice to wear, and you know, I commend all my clinical colleagues in what they have done in combating this virus and the way they've worked. So from that point forward, it all changed. Staff were redeployed, thankfully, to the infection prevention team. We were able to pull back one of our previous colleagues who helped us maintain our day-to-day work. As you can probably understand, that for some services you can stop a service and that service is stopped. In infection prevention, you can't stop your MSSAs, your gram negatives, your C. diffs. They're still happening. They still have to be reported through the mandatory systems. So that work still had to be covered. Those patients still had to be cared for, along with the patients that had COVID. So what we did, we split the team. So Arlene, James and I managed the COVID, and Karen and Emily managed the day-to-day IPC work that we couldn't just stop and shelve. We reduced, obviously the audits were stopped, which was we were thankful for, but some of those did continue on the back of the C. diff outbreak that we had on Ward 4. So we continued the C. diff audits, and then we introduced a COVID-19 audit based on the guidance that we were being given. But at the early point, we weren't being given any guidance, as David had referred to. So Alex and James and teams at the front end were actually working and rejigging the Ebola guidance and trying to cobble together, you know, something that was safe and secure for our teams to work with until we received some guidance. Anyway, thankfully that guidance did present itself, although it was a daily change, which was difficult to manage. You could, you know, log on in the morning and it was one set of guidance, and then by 5 o'clock in the evening, they'd added something, taken something out, retracted something. So that was very difficult for the team and the teams in the clinical areas to manage, because there's an element of getting that out there as soon as you can, so that the teams are aware of the change. So that whole communication was quite difficult, and sometimes it just meant a trawl around the areas to make sure that they'd seen their emails, they'd seen the comms coming out, and that they were aware of the change. As a team, we changed our working hours. So the infection prevention team were working 8 till 6, Monday to Friday, and covering weekends. We had a reciprocal on-call with Bradford District Care Foundation Trust, which we stopped. We both did our own individual on-calls to maintain that level of consistency, because things were changing at a rate of knots. And for us to be able to manage 2 different organisations on and on call was not sustainable. So we took that decision quite early on. So obviously regarding PPE, fit testing, it was quite amazing the number of people that hadn't been fit tested. And one of the key things within the team and the amount of queries we got were around fit testing, PPE, and it was a constant, knock at the door, and there'd be 3 clinicians saying we need to be fit tested, we've got to work tonight. So that was quite difficult to manage because we had very few fit testers in the organisation. The main ones were within my team, who were already busy with dealing with the sit reps and updating guidance. So we've moved forward with that. We've got the external company that now come in and provide fit test training. That's gone on through the last year. We've had 3 sessions in February, and hopefully now we should be nearing or just over 100 fit testers in the organisation. So we're in a much better place than we were this time last year, and that will be an ongoing change to use the external company to make sure that we've got fit testing available to staff, and that we have our own internal rota of fit testing sessions. So I think that has proved difficult, along with the PPE, the changes, the unavailability of masks that people have been fit tested into. So they were all quite challenging because then people had to be refit tested. We had to make decisions about availability of the silicone FFP3 masks. And I think Marco's going to talk about powered hoods in ICU, etc. So from a PPE point of view, from an IPC background, the use of a sessional PPE and having to double glove in theatre ICU and ICU was quite a challenge for us, because that isn't an IPC principle that you would like to be using full time. But I did reflect back on the Ebola outbreak, and it was something that was used in the Ebola outbreak. So I felt reassured that, to keep patients safe and to keep staff safe, that if we did it in the correct way and we had some set guidance, and then I felt assured that I was okay with that guidance. But it did resonate with me that that's against all our principles in reality. So the other things that we're learning for ourselves were the things around working with Alex, AAU, ARCU, ICU, on all the ventilation, the pathways, Perspex screens were going up everywhere. We had a COVID budget that we could tap into. So a lot of things that we required were all of a sudden available to us and were in use and in practice very readily, thanks to David's team. And that was something that wasn't, ever seen before in the IPC world. It was usually quite a struggle to get things progressed, and all of a sudden we're front in line, and basically we could have more or less anything that we asked for that we could justify would increase, patient and staff safety. So that was quite a bonus, and obviously that is now in place and we've future-proofed the organisation. So that's the good that has come out of this virus. And outbreaks, as Amanda has mentioned, the outbreaks really didn't feature in wave 1, but 2 and 3 have definitely seen, that increase as soon as we started getting an increase in patients. We got an increase in hot cases on cold areas, creating contacts. So there was work that we did around creating contact wards. So we've used Ward 19 and Ward 9 in the past, so that we can remove those contact patients off the cold wards, deep clean, make sure the area is ready for patients to be admitted and keep that flow through the hospital. and we introduced obviously increased cleaning and a new guidance on Ward 4 that we're piloting is a time to clean guidance, which Amanda has asked me to speak about. And this is something that we've adopted from Calderdale and made a few adjustments. So every 2 hours for 10 minutes, unless you are doing something critical with a patient, you take part in the cleaning of touch points, toilets, door handles, handrails, anything that has frequently touched, your laptops, your carts, your mobile carts, and you do that for 10 minutes. And that just gives that initial, you know, it's working well on 4, it's good for team morale. Every single multidisciplinary team member is asked to participate, and it just gives us that increased level of cleaning. What we've also added into our guideline is that in that 10 minutes you ask patients to clean their hands or facilitate that they can clean their hands, so that they've had that extra hand hygiene opportunity offered to them throughout the day as well.
Lovely. Alison, thank you for that. That's really, it was lovely to hear, and quite a stark story from where we were last year to where we are today, but thank you for that. That's good to hear. I'm going to ask Marco to come in at this point if he's still there. David, we can't see him on screen, that's all.
Yeah, he is,
yeah.
And I'm controlling the mouse because I've not cleaned this touch point before Marco uses it, just to be clear.
Okay, right. Okay.
Thanks, Marco.
Okay, good morning all. So I've been asked to speak about 3 topics. The first is who or what is Public Health England, okay? And we all know that we've been following PHE guidance, so I'll give you a background of who or what that body is. And the second thing I'll be talking about is what have we done as a trust above and beyond what PHE recommends, okay? And the third I'll talk about is something topical in the news, talk about the variance of concern, what it is and how does it affect us. So first, what is PHE? You all know we're part of PHE guidance. Well, PHE is a part of the Department of Health and Social Care. There's Public Health England, there's Public Health Scotland, Public Health Wales, and Public Health Northern Ireland. It does what it says, so it aims to protect the nation's public health and to reduce health inequalities. We all know it responds to national health emergencies, but it does other things as well. From my point of view, it provides specialist laboratory services. So it provides specialist microbiology services like testing for unusual bacteria, viruses, and parasites. But it also does other things. It does things like mental health, it does nutrition, smoking, healthy eating in children. So it has a hand in all our school meals, and clean air as well. There's 4 big regional centers across England and many local centers. And our closest local center is in Leeds. It employs around 5,500 full-time equivalent staff. So it is a very big national body. PHE, just to let you, PHE doesn't work alone. It consults with specialist bodies or the specialist national bodies, one of which is a body called NERVTAG, which is National Emerging Respiratory Virus Threats Group. Okay, so you know the list of AGPs that we have on from PHE guidance. PHE has consulted with NERVTAG to come and they come up with this list of AGPs. Okay, so that's what Public Health England is, and it can continue to follow PHE guidance. Now, in addition to PHE guidance, which we implemented, Alison talked about, we've also done a couple of things above and beyond what PHE recommends. I can think of 3 examples. The first is we have redesigned our intensive care unit. So, as you know, people in ICU, the patients require certain ways of delivering oxygen to them. To the lungs, and that generates aerosols that are potentially infectious, and therefore they're potential infectious to the staff. What we've done, we've put in a large extractor fan at the end of the ICU, and what it does, it extracts the infection aerosols from the unit outside safely into an open green space. And that achieves two things. First, it creates a negative pressure within the unit, and with that negative pressure blowing in one direction, then it protects our nursery station and the corridor and other walls as well from potential infectious aerosols. And the second thing it provides a minimum of 10 air changes per hour. So an air change is when the entire room the air gets changed per hour. So a minimum of 10 air changes per hour is what is the HDM recommendations for infectious diseases unit. And in addition to that, we've also put in donning and doffing stations, and we put in a couple of hand wash basins as well for staff. An additional layer of protection to staff we've also provided to ICU and also on our crew is the powered respirators or the powered hoods. So what they are, it is basically a hood across the head, neck, and upper chest, and it has a pump, a battery pack, and a hose that connects to the hood. And what it does is that it filters the air and pumps it across the mask and out through the chest. And what does that provide? A convection of current, so aerosols can be and doesn't get into the user. And the advantage of that is that in areas where they have continuous intense aerosol production, like in ICU and RQ, it relieves the user from continuous wearing of FFP3 masks for hours and hours. We know that FFP3 masks, if you wear for long time, causes pressure ulcers and bleeding and scarring across the face. And so it's more comfortable, it has a cooling effect, and for some staff who have beards, they are able to have their beards where they wear the powered hoods. But there are disadvantages as well. For example, because the battery pack is very noisy, the pump is very noisy, then there's some potential hearing problems in communication. And it cannot be used in some areas where they would like to have the power hoods. For example, in theaters, because it's not recommended to be used over sterile site surgery because the air blows over the sterile space, so you cannot use it in that way. And the third thing we've put in place, we purchased a number of 14 IQ air units. Now, IQ air units are HEPA filters, so they're electrical HEPA filters. It's the same high-grade filter that we use in the laboratory in our biosafety cabinets to protect us against bacteria and viruses. So what it does is that it's a high-efficiency filter that can filter out bacteria and viruses. So we put it in areas where there's continuous aerosol production, and it helps to clean the air, as you say, to increase the air change per hour. Just to give an example of how useful it is, for example, in some radiology rooms, we have been able to reduce the downtime from 60 minutes after an aerosol generating procedure down to 20 minutes. So that's how useful it is. So these are 3 examples I can think of that we've implemented here at Airedale to help protect our staff. Now, finally, I would like to talk about the variance of concerns. Now, when you read in the literature, it's very topical at the moment, but we have to be mindful to identify what is a VOC or variant of concern versus a VUI, which is a variant under investigation. So VOC or variant of concern is when there's a mutation in the genome that has either pathological, immunological, or epidemiological significance, i.e. increased transmissibility. Okay. The way it is named is a VOC, variant of concern, and it's followed by the year. It was identified as 2020, and in month it was identified as 12th of December, and then a number after that. So the current variant of concern that's circulating in the UK, first identified in Kent, is VOC 2020, 12th of December, and 01. That's how it's named. And then the name goes on 0200 and so on. A variant under investigation is when a mutation is being identified, but we don't know the significance of that as yet. And once we have clear evidence of pathological, immunological, or epidemiological significance, then it's relabeled as a variant of concern. Now, what is a mutation? Well, we know that a mutation is always described relative to a reference genome. So the reference genome is called Wuhan 1. that was the first patient that had whole genome sequencing that was performed and deposited online. So all future genome sequences are made in relation to this very first reference genome sequence. We know currently there's over 4,000 mutations that were identified compared to the first sequence that was deposited online in January 2020. But not all these 4,000 mutations are clinically significant. The section of most interest is those that affect the spike protein. The spike protein is protein that binds to human cells. So if you have a mutation in it that increases binding to human cells, you can imagine there's potential for either increased pathogenicity by affecting more organs or increased transmissibility, like what we see in the new variant as in the UK. There's currently 4 variants of concern circulating worldwide. The UK variant, there's 2 Brazil variants, and the South African variant, as you're aware of. So therefore, all these variants have potential increased transmissibility and therefore infectiousness, and therefore the importance of continuing to wear appropriate PPE, hand hygiene, and to protect ourselves. That's all for me. Thank you very much.
Thanks, Marco. That was fascinating. Thank you for that. I'm conscious of time, and we filled our time really well. So if people want to ask questions, if they want to type them into the chat box, and Katie and I will pick them up. I'm going to move to David. I'm really conscious of the time we've got. So David, over to you, and then I'll come to you, Trudy. And Alex, if there's things around ED as well, I just want to make sure we've got time to pick those up. So David, PPE.
Thank you, Amanda. So I shall be brief. So what I'm going to talk today is about, the history and where we were with PPE, where we are now, and I think hopefully I will give staff some assurance that we're in a very strong position with PPE. So when we went back to the beginning of the outbreak, we were in a very unusual position because, despite there were only certain areas across the hospital which used PPE, and then obviously within a very short space of time, we were having to wear PPE in all areas. And you can see that the demand, not just nationally, but globally for PPE was absolutely huge. And some of the PPE went up tenfold in price. There was a significant issue with the supply, and the supply chain wasn't able to meet that demand. So very early on, we were literally hand to mouth with the supply of PPE. We were very fortunate at this trust that we had no shortages of any of our PPE supplies at all. That was really, I think, testament and down to the hard work of Nasheen and her team, who worked tirelessly to try and find PPE from anywhere. And believe me, we were at that time, we were ringing around suppliers, we were, going on eBay, anywhere we could get sort of, good quality PPE, we were. But we're in a very different position now in that the supply chain has caught up. There is significantly more PPE manufacturer. There was very little in the UK, and we now make some in the UK, but we're in a very strong position. And I think reflecting on things, we didn't know how bad the second wave was going to be or where we're going to get a third wave. So we took the decision to be safe that we would try and accumulate as much PPE as we could. And you will have seen around site there are a number of shipping containers appeared, and that was really our contingency stock, because we were unsure of the supply chain and we were unsure about how COVID would affect us and for how long we would need it. But we are in a much better position now where we have adequate stock of good quality PPE, and it is readily available through the supply chain. I think one message I was going to say, I think David stole my thunder earlier about the fact that, actually getting feedback from users. So whilst we actually deliver the PPE and we ensure its supply, what we're getting from the centre, we don't get to choose. We get sent, it's called push stock from the centre. So at one point we had the army involved in the logistics and distribution of PPE. It was delivered in the middle of night, but now we get a push stop from the centre, and that's why we get different types of PPE. We can't choose exactly the same, but whilst we deliver it, we're not wearing it all day. So that's why it's really important that we get the feedback from clinical teams that wear the PPE all day, and then we can act on it, as we did with the safety glasses that David mentioned before. So I think before I pass on to Nasheen to talk about some operational aspects of PPE, I've just got two more messages. The first one is around, I think we've had a few queries initially around the masks that we have at the entrances. They are fluid resistant, and we only purchase type 2 fluid resistance. And I think on a separate issue, I just want to talk about space and office moves while we're on here, because when COVID came, first of all, it was extremely disruptive. We had to move staff that were based on hot wards. We had to space people out to meet the demands around social distancing. And I just want to say how accommodating staff were. It was terribly inconvenient, but everybody just, got on with it, really strong mentality, and we managed to rehouse everyone successfully. It is a jigsaw that I'm not looking forward to putting back together, but we will no doubt have to do so when COVID goes and we're able to go back to how we used to work. So I'll pass over to Nasheen now to talk about the operational aspects.
Thanks, David. I'll just touch briefly on what we do operationally. So as David said, we get the push drops centrally on a daily basis from NHS England. The products and volumes that we receive are based on the daily sit rep that we submit through the Foundry to the national team. The key role of the PPE team is to check the volumes on the key areas such as ED, AU, theatre, ICU, and all the inpatient wards every morning. Then the PPE team top up they top up on a daily basis in each area. The non-clinical areas are checked on a weekly basis, so that's generally the wipes, masks and hand gel that they get. We've changed the way that we work as well, in terms of we are on call 24/7, and we've also got a dedicated PPE email address for any ad hoc requests that the trust require, which I'll put onto the messaging service shortly. I just want to say that we've worked very closely with IPC to make sure that all the PPE that's distributed in the trust is according to the required standards, and also with the WIAT colleagues across the region. But yeah, I think the service is seamless now. As David said, we were in a different situation this time last year, and we'll continue to support the trust with the delivery of the PPE.
Thanks, Nasheen. That was great. And COVID doesn't only present a clinical challenge, does it? It presented an absolute logistics challenge for lots of people. So thank you for that. I'm just keen to just bring in Trudy, because I'm conscious again that COVID wasn't just about being in the hospital, it impacted everywhere. And I was keen to just have a couple of minutes, Trudy, if that's all right, getting a sense of what it was like out in community from a COVID-19 perspective and an IPC perspective.
Yeah, thanks, Amanda. So as Amanda said, in terms of services outside of hospital, they cut right across health, social care, primary care, voluntary sector services. So it's not just health services impacted, it's been right across, and I think people will appreciate there's been some variations in terms of some of that. But what I'm going to share with you this afternoon are just a bit of a flavour of what life has been like as a community service and for the frontline staff, and some reflections really. And the feedback that I've had from teams sort of breaks into two sections really. One is predominantly around communication actually, and the other one is a bit more around the practicalities. So the communication that staff have felt in terms of PPE particularly, and wearing PPE, as the impact that it's had in terms of, and it will have been the same in the hospital, in terms of their interaction with patients and families and carers, regarding the wearing of masks, the social distancing, the impact of that, and particularly in terms of delivering bad news or delivering end-of-life care. Bearing in mind that for our district nursing teams and collaborative care teams involved in end-of-life care, in Craven, which is a huge patch geographically, about 450 square miles, district nursing teams would normally care for between 7 and 9 people a month on the end-of-life pathway. In April and May last year, we were up to 50 people. And the length of time that people were involved was ranging from first visit to their death, could be as little as 3 days. So building up that rapport, it was a real pressure on teams and individuals. With students actually travelling in cars together, that's been a real issue. You know, we're adhering to the guidance, one person sitting in the back diagonally, windows open, mask on, in all weathers. And again, normally that time between visits is a time when mentors and students are interacting and discussing cases, and then that's been impacted as well. Colleagues following on from joint visits around, particularly around complex care needs, and debriefing around end-of-life care, for example, that again takes place in the car, but staff have had to travel separately to visits, which has had an impact on travel time, cost, although that's not the biggest issue, but it is still a concern. But also, you know, just that time to talk about what's been happening. And, you know, we've had new healthcare support workers, for example, who have witnessed their first death and have then had to travel on their own, in their own vehicle, 30 miles to the next point of contact with their supervisor or registered nurse. So it's had an impact in ways that we perhaps wouldn't have necessarily recognised previously. Managing expectations of the people that were visiting at home, you know, it's been quite hard to get into some people. They've been fearful of health professionals bringing the virus to them. And actually, in terms of going into households where you've never been before, what you're going to find, and how concordant people are with guidance and their family members. So community staff have got to engage with people, their visitors in their home, and have no control over that. And that can be a source of stress for staff as well. In terms of communications, again, some of the impact that we've touched on around social media and some of the messaging about availability of PPE, it hasn't been the same as it has been in the way that David's described across the country. We've been very lucky, but hearing about issues elsewhere causes anxiety for staff, and obviously has raised questions around discrepancies across services. There have been different agencies wearing different levels of PPE when visiting the same person because they've had access to different levels of equipment, ranging from a mask and no apron, potentially with domiciliary social care, to the full nearly hazmat suit that the paramedic might arrive in. So it's been quite confusing for people, particularly in the early first wave. We've been working really collaboratively with partners in primary and social care, but there've been access challenges. Obviously, care homes became really fearful again of visiting health professionals, and this is ongoing now as well. You know, trying to get access to people who need care, it requires some really sensitive discussion and collaborative working so that it doesn't escalate into a safeguarding issue with people being denied access to the care and interventions that they need. So there are some really sensitive conversations that go on in terms of our collaborative working with partners as well. Patients have expressed concern about professionals turning up to visit them wearing PPE and what their neighbours might think about them and what risk they might then pose. So, you know, we're getting feedback from other people as well. People refusing to attend hospital because they're worried about catching COVID in healthcare settings. So we've seen an increased level of acuity on occasions that teams are having to manage for that reason. We've also had staff shielding and working in an agile way, working from home. That's become actually business as usual, and we've normalised that in some ways, which is a good thing. We've been using technology. We've had the benefit of laptops and agile working equipment, which has been good. But I think what it's done is change the culture of people feeling they've got to be visible, to demonstrate that they're working. And we've had some really valuable contributions from our staff who've been shielding. In terms of some of the practicalities, and people may have heard some of this before, but you know, the donning and doffing of PPE outside people's homes in all weathers, you know, that's been the reality for staff. And whilst it was lovely in the first peak, you know, we had all that lovely spring weather, actually that has continued now through hail, rain and shine, snow, gale force winds, and it's really time consuming and requires staff to have that additional equipment. They're also donning and doffing their uniforms when they finish their shift before they go into their homes, so that their uniforms can be washed, and they're reducing the risk as much as possible to their families. That's been a real worry for staff as well. And like other departments, they've been having to clean their equipment between patients, clean their cars, you know, lots of things that they've had to do in addition to their usual routines as well. We've been having twice weekly PCR and lateral flow testing for quite some time now before the wider rollout, and that's been part of the support to care homes. So the teams visiting care homes regularly have been doing twice weekly tests for quite some time now. And again, still getting some pushback actually from some of our care home colleagues about being able to demonstrate that staff have got negative tests. So again, fairly sensitive discussions are still ongoing. We've been doing the right thing in the way that David perhaps he was talking about earlier in terms of the guidance. And sometimes doing the right thing has been quite stressful for staff because it's been about that increased workload, but it's also been about the reality of risk in terms of the guidance we've given them about wearing PPE and the policies and procedures to follow. They've been working very differently to support outbreaks in care homes as well. And it's been there've been some real positives in some ways in terms of the way that the pandemic has impacted on our thinking, but also I think what we're still hearing now is around the impact. We certainly haven't had a lull. We're not back to low rates in terms of the circulation of COVID, particularly. We're not seeing it on the caseloads, but the impact of it is certainly still, demonstrable, if you like. And I think just to remember really that the vast majority of people with COVID aren't in hospital, they're in their own home or a care home. So I'll end on that note.
Thank you, Trudy. I'm really conscious of time, and I'm going to give the last minute to Alex, who is probably at the front end of our acute response, definitely. So Alex, I'm going to give you the last minute and then I'm going to draw it to a close.
Thanks, Amanda. I think for me, really, it's just to say that I've been in a really privileged position because I've sat regularly with the clinical reference group and heard the group discuss the guidance that's changed and how we're going to implement it. I've sat regularly on the Silver Command meetings and seen the work that David and Oisin have had to do to provide the equipment. But probably more importantly than that, I've actually worked on the front line and worked with the frontline teams throughout. So whilst it's one thing delivering the messages and making the changes, it's another thing asking the teams to buy into it and to comply with it and really feeling what it's like to wear that PPE, to work in a what was initially quite a fearful environment, I suppose. But I think that the trust has hopefully, and I think it's certainly been the case at the front end of the emergency department, delivered a really quite clear, consistent message throughout. And we were very quick actually to move ahead and move to universal precautions, full PPE for all patients at all times in the ED. And the amount of anxiety that alleviated from our staff was really quite remarkable. And I'm glad that we did move quickly. And the other thing to bring in, I know there's a lot of noise at the moment around the different levels of PPE for different masks based on some evidence that's coming out around FFP3 versus surgical face masks. Just to say that for those of us in the ED who see the undifferentiated patients, the sickest patients, we've actually had really low incidence of staff sickness in the emergency department. And I think that's through really consistent use of PPE throughout the pandemic. And we're not wearing the full hazmat suits. You know, we are in surgical face masks. We have been consistent with eye protection. We do wear gowns and gloves for every patient. And that's been the case since the 21st of March, which is when we changed to that. And it's really played out that we haven't seen high staff sickness rates. We've still been able to deliver care. And the teams have really been remarkable in how they've adapted to it. So it's really just a thank you to the staff for adapting in that way from me.
Thank you, and I suppose that brings it to a really nice close. And I'm really sorry we've kind of filled the hour, and I think it's been really fascinating, and hopefully it's been fascinating for everybody, and just listening to a variation of experience. And I just want to end on the comments around the thank you to Arku and Nikki Dembo, and a recognition of wearing full PPE is not easy, and it's been for a long time now. So thank you, everyone. If there are other questions and people want to raise things, then please feel free to email, certainly me. I'm happy to have any questions raised after this, really, and we can direct them in to the right people to answer them if anybody has got any queries going forwards. So with that, I just want to say thank you to the panel. Thank you for Katie for organising these. I think these might be a method going forward of really good interaction with teams, and hopefully you've all enjoyed it. So I will draw that at 12:30 to a close. Thank you.